Hi, welcome to this demonstration of FTI Catalyst. We appreciate your time. Thank you for joining us. And we look forward to a discussion and an exchange of ideas about how to best deliver data to your enterprise. We understood from previous conversations that there are certainly some bottlenecks in delivering reports. There's various disparate systems that you utilize every single day for managing parts of your business. Our goal is going to be able to show you a way in which we can bring those disparate parts of your business together so that you can easily manage your business in a way that helps you meet compliance, revenue, as well as other value and quality goals that you have for your enterprise. So just starting off, a look at FTI Catalyst, you see right here on this very screen, you see an easy way. You can use your tablet or your smartphone to easily access reports. So not only am I going to show you a way in which physically your way of managing your data in terms of not looking at a spreadsheet, but instead looking at your smartphone or another tablet device, easily facilitates your learning about your organization and being smart about your business in a way that Excel just doesn't allow you to be now. So let's look at your business in terms of a very broad spectrum to begin with, and then we'll drill down. Right now, the value equation is all the chirping of the business. Most of the industry players, my competitors as well as your competitors, are all talking about value, and we know why. We know CMS is talking about value. We know that you have value propositions for your community in terms of being a top-ranked hospital. You want your patients to choose your hospital over the competitor down the street, whether it's for elective surgeries or an ambulance ride. You want people to look at your hospital as valuable, as a resource, as a place where they want to go to get better. Right now, the dotted line is showing you where we are in terms of value. And the industry right now is plagued with high costs. Well, we'll talk about how ACA is affecting that, but the bottom line is that we know that your pool of money of reimbursement is shrinking, and you still want to be able to provide quality care at low prices. So how can you do that? There's going to have to be a way to grow margins because they're going to get thinner. There's going to have to be a way to recover capital, and there's going to need to be a way to be more efficient. So productivity, profitability, and performance are key aspects of a business intelligence solution so that we can take this equation, if you will, and understand better the equation of the line of what will put us in this position. Patients all over the world are ranking hospitals. Here's one from Australia. We're looking to help you make it rain thumbs up. This is something that every hospital wants. You want to see that you are highlighted by your community, by your peers, and even by your competitors as being a top-ranked hospital. And this article says patients happy to rate their private hospital as the best. This is all the way down in Australia, so the mechanisms that are affecting healthcare in the United States in terms of costs and in terms of value are worldwide. All the way down under, this is a concern. So we want to get you into a position where you can compete in terms of value and quality and patient feedback against the best. And we believe that having business intelligence as performance management is the way to do that. And that's really what business intelligence is a way for you to manage your performance every single day. So I didn't really get cute here with a bunch of images and arrows, but what I'd like to highlight to you as we get started is that productivity, case margins, operating margin, utilization, quality, finance, and contracts are critical areas where we can assist you in your reporting, in your abilities to intervene on cost overruns, your ability to intervene on areas of productivity, performance, and profitability and correct it sooner. So nurse ratios and being staffed to target is very important to you. Recouping labor by labor care role and labor choices, those costs which are burdening your margins and burdening your overall operating margin and your flex budget for labor can be corrected. So we're looking to integrate various different systems to put together a management screen for you, which I'll show you, which will assist your nurses in being empowered to make changes to the labor pool based on your average daily census. Case margins and variable cost physician preference items. We want to look at a way in which you can see physicians against their peers. Is there a physician, for example, that has a lower margin, contribution margin, but other physicians of the same DRG are more profitable? Are there cases where a certain length of stay or readmission is more prevalent for one department or one physician or one DRG than the other? Are variable costs related to high levels of acuity, or are physician preference items really just held in one quadrant of, say, orthopedics and implants, for example? So we want to help you see the core drivers and eroding factors on your case margins in time enough where you can make a difference. So we also look at operating margin and capital recovery. We look at where are you spending most of your money. And when we load your historical data into our system, voila, you're able to see that very easily. Utilization and throughput, we're talking about blood bank, we're talking about OR, imaging, we're talking about the ED, obviously. And so we want to help you make sure that if you're discussing a build-out of a new OR, for example, or you're talking about staffing the ED on certain days and trying to understand when you're most productive, we want to help you see how you are utilizing your resources. And are you able to engage in throughput, to put patients through the ED in an effective way? What is the time to see a physician? How many become residents? Where were they transferred from? So your business is intertwined from the ED right through the OR and your acute care setting, because I saw a sign for many of these different types of EDs throughout the country. Wherever you go to a particular town, it'll tell you what the ED wait time is. So I know that you're concerned with your emergency department and how open for business are you. So this leads us to quality and value. And to what extent is your hospital system valuable to CMS in terms of your Medicare population? Are you engaging in the proper activities to show improvements for your total performance score for value-based purchasing through Medicare? As you know, next year it will include Medicare beneficiary spending as one of the criterion for reimbursement. And at 1.25% currently as a bonus or potential deduction in your Medicare reimbursements, it's important to understand if you're meeting the requirements for clinical measures, patient process of care, and the patient experience, as well as mortalities and how you're trending. So Medicare and CMS has their own vision of value, and you have your own as well, and it might be cost effectiveness, growing services, better contracts for your patient population, and being able to have access to, say, financial drill downs on service line level information down to the patient level and provider level of detail will allow you to be able to steward your philosophy about growing your business in a more real-time manner. Because what we've learned is that what you're currently doing is using Excel, and every 30 to 60 days, you're looking at your key performance indicators. But what we'll find is that you don't have time to intervene and change the outcome, because your disparate source systems, which contain information about length of stay, readmissions, costs, variable costs, and overall performance, are latent. And because employees don't have the ability to interact with data, you're not able to be nimble and agile as you either negotiate contracts or as you try to understand your business by drilling into it in a way that allows end users to easily interact with data, answer and ask questions, and improve your business, your bottom line. So how is this all constructed? How does this come together is the big question. And you've done some research on business intelligence already, and what you already know most likely is that it starts with building a data warehouse. This is a key element of the development of a BI system. And the 3 Ds of data delivery we would refer to as data warehouse, data model, and dashboards. These are 3 core attributes of a successful BI installation that we offer you. My competitors do not offer you a data model and dashboards out of the gate. If you look at class surveys, you'll understand that one of the key conundrums to going live with business intelligence is the creation of a data model. There are barriers like cost and consulting as well. And of course, there's the development of dashboards. So typically a company will sell you their services and their abilities to put together a data warehouse and put together a data model and put together dashboards for you, or just provide a tool set so you can build the dashboards yourself. What we've seen in the marketplace is it is littered with remnants of projects that never really got underway because the data model didn't get fully put together. The tool set wasn't fully implemented and trained. A staff member might have left and not come back. And we see very shallow integrations or deliverables in terms of the end user. What we have for you is a fully built data model that encompasses all the core attributes we know that you're after that we'll get at in a moment. And we also use an industry-leading tool set. And Gartner reports that Tableau and Oracle, which we utilize in our tool sets, are two of the leading tool sets in the marketplace. And of course, we offer dashboards. So in a 90 to 120-day period, what I can do for you is build a data warehouse, bring your source systems together in one unified repository. And with my data model, I'm in a position to deliver dashboards to end users in just 90 days. And since I use a tool set that is by an industry leader like Tableau and Oracle, you're now empowered to teach your own employees how to tie into that data model and build other dashboards that you want. So maybe you want to open up a bariatric center for excellence, which you don't have now, and you're capturing BMI and other attributes. That's something where you can build out another dashboard and tie into our data model. So we really do springboard you in a way that no other company in our industry can do. And this is just the multiple platforms that have been analyzed by Gartner. We're looking here at Tableau. Really is one of the leaders right next to Oracle, IBM, Microsoft. So when you buy FTI Catalyst, you get a data model, you get dashboards, and you get the top industry-leading tool sets from industry vendors that will support you with their tool sets and provide top-ranked tool sets based on end-user experiences. So the end-to-end solution, the overview here is to, as we've already discussed, analyze your source systems of record. Where do you keep length of stay or readmission or patient data? We want to bring those source systems all into one warehouse. And we bring it all together into one warehouse. We're in a position with our data model, which lies within it, to deliver dashboards. So this is an overview of an end-to-end solution of analyzing source systems, integrating data. We are data warehouse and data management experts. And to be able to store this data and deliver it within 120 days truly is an industry phenomenon. Now, our balanced scorecard approach is one that is sort of the holy grail, I would say, of where you want to be today. When we began our meeting, I asked you on a scale of 1 to 10 how you would rank your current ability to do reporting, and you said it was a 5. We also asked you what it would take to make it a 10. Well, you wanted predictive analytics and a number of other things. It looks like we're going to get you to about a 9. We're going to give you financial metrics, operational, quality, staffing, the ED, productivity, and core measures. So we're capturing all of the business functions you interact with every single day. I mean, if you wanted to have a dashboard about the productivity of the gift shop, we could even put that together for you. But these are the core attributes that make up your bottom line and your revenue every single day. You have financial capabilities with our software to drill into profitability by service line, by physician, by DRG, to drill in by payer mix, case mix, charge posting, and other reports. So this is what we've come up with after a experience where we raised this software in an actual hospital market in Western New York. And Dan Gerena is our product manager who stewarded this course. He managed business intelligence and analytics in a 5-hospital setting in Western New York at Kaleida Health, which we know you're familiar with. And the results is one thing to point to. Organization went from a $60 million loss to a $30 million profit, due in part to enhanced ability to measure and monitor results. Now, if you can't hold people accountable for results, you can't measure things, you can't improve. And to this date, I don't think anyone's ever done a press release talking about the power of Excel in recovering money. It's a complex solution that's powerful, but doesn't offer you the real-time data and ability to interact with data that you need to steward your course towards profitability. So let's look, for example, at finance. Right now, you're looking at a patient profitability overview. This is an overview that is showing you by financial class in the Department of Orthopedics for all sites in a particular date range where patient visits fell. And I'm looking at all the different insurers, and you see that I have a legend on the right-hand side. And the legend is showing me very easily with a shape different types of encounters from different types of payers. If I wanted to see just all commercial insurers or all Medicare, I could easily just highlight all Medicare and see how they plot. And I could begin to drill into understanding what was it that caused that particular margin to be so low. So the spirit of the tool is that I could also change my parameters and say, let me look at DRGs, APR, DRG, and DRG for Medicare. I could look at it by surgeon or by surgeon group, and I could easily see for any date range or any variation of service lines, whether it's all service lines or just a few, and I could begin to understand either just by hospital, the outliers and variations in care processes that might lead to a lack of profitability. So right now, when you look at Excel, you have to print out reports for orthopedics and a number of other types of... Hello?
Hello. Oh, I'm sorry.
Hello?
I'm going to hang up. I'm sorry. I dialed in by mistake. I apologize.
No problem. I'm just recording. If you want me to, I'm just...
No, please. Yeah, that's fine. Oh, now you can pause it there. Yes, good. No, I was supposed to dial into Beth.
So we're back after a brief interaction. So the spirit of the tool is for you to be able to interact with the data, to be able to ask questions and drill into data that you want to see more about. You could see something that catches your eye about a length of stay or a particular physician, and once you're looking at this data on a regular basis, you become more familiar with the things that are outliers. And when you become familiar with outliers, you begin to understand what's driving revenue as well as what's detracting from revenue. Because if everybody fell in the middle, you'd break even, right? So the idea is to understand not the cluster, but those things that are on the outside looking in. Because there's a certain amount of things that lead to losing money and making money on certain cases. But we want to understand the people here on the far left-hand side. We also want to understand what drives these cases to be so profitable. And so by being able to answer questions, ask questions with this data, it's very easy to facilitate that. So here we're looking at the same data. If I were to look in the tables of the database, which I can show you that very easily. You could always bring all this information over to Excel if you wanted to, or for a board meeting, or for some reason you wanted to put bits of information in a spreadsheet, you could. But what I'm looking at here is a different way of representing the data, and that's what business intelligence does. It creates data visualization tools for you so that you can see data in a much more enlightening way. So right now, instead of looking through the outliers of a spreadsheet where all the digits of a spreadsheet are sort of camouflaged amongst themselves and highlighting that data with a marker, collating, putting it back into another spreadsheet, I see right away that Jean Crabtree is separated from her peers. And I may want to understand that better. So here's all patient encounters. Again, I could change the number of encounters. I could change the department or make it all departments. But I can drill in and find out specifically what is driving this particular bubble to be where it is. It's showing a high volume. I'm showing margin per case to be pretty low. I'm seeing total charges to be pretty high. So a lot of effort is being created on these patients, and I'm wondering how profitable these cases are. Down below here, I've selected this particular physician, this brown physician here, this brown dot. And what it's showing me is that this physician group has a number of encounters that's on the rise, but margins are on the decline. That's no good, obviously, because they're seeing more cases and losing more money. And it's going to exhaust your system of resources. When we get into payer mix, we're looking to understand your patient population and help you understand the value of the contracts that you have. So Blue Cross, Medicare, other insurances that you might carry, we're providing you with a visual representation of the Department of Orthopedics in a particular month and date range so that you can see the average margins. They're averages of averages. So we see the grand total average margins based on these patient visits. So we see volumes by financial class. So Blue Cross, out of all the patients that you saw in orthopedics for this given time period, which is roughly about 3,000 or so, about a third of them were Blue Cross. And we might want to decide to analyze the profitability of all those Blue Cross against the Medicare patients, what types of cases we're seeing, what's driving these margins. And below we have per case payments, direct costs, and profit margins. Case mix acuity, this is a very easy screen to drill into as well. I want to understand from this screen how severe or how acute are my cases for every single month by financial class. So I see financial carriers here, and I see different months. And as I scroll across to Medicare, for example, the month of April, I notice that I have a 4.6 or so for my case mix acuity level. That case weight is very, very high. So I may want to understand that by provider. I may want to understand, what DRGs did we see, and were those profitable? Is there a relationship between acuity and profitability? Does it always mean that if you do a bunch of dorsal fusions that you're going to make a bunch of money? Or does it mean a lot of money is going to pass through your organization and not a whole lot is going to stay? We want to help you understand those drivers. Down below, I easily see another way of looking at the data. Again, if this was all on a spreadsheet, there's not a whole lot of conclusions you can draw to it when you've got 20 or 30 pages and 100 tabs in a spreadsheet. We want to help you be able to draw conclusions by seeing outliers and understanding visualization. I would like to understand a little bit about this commercial carrier while they're all the way out here and separated from their peers. Maybe I want to organize it by provider. We noticed before Jean Crabtree. She had a very high case mix acuity as well. She saw a lot of patients. She was separated from her peers. Maybe you want to drill in and see what story is being told by this data. Lags in charge posting. When charges are not posted in a prompt manner, you risk lack of reimbursement, especially if it goes over 2 weeks to 30 days. So I'm showing you red dots in every single unit for every single date of charge posting. In this particular unit, for example, on this particular date, I have a proxy for charges. So these charges, these lags, serve as a proxy for volume. And I begin to understand by carrier, by department, by unit, and even by provider, how am I doing in terms of charge posting? This means we saw the patient, we provided the services, but since the charges haven't been posted yet, no one's going to get paid. So we have to decide why that's happening and track down that reason. Because as you know, after a couple weeks, this really begins to spiral if people fall behind on charge posting. So that's finance. And with one click of a mouse, and without having to ask decision support for a report, if I learn something in my financial drill downs, maybe now I want to learn a lot more. Maybe I want to take a look at discharges, length of stay, discharge management, admission sources. I want to look at the profitability of the ED, OR, room charges, and maybe other reports that you have in mind. With one click, I'm interested in seeing a profile of discharges. So right now I see different carriers. Okay? It's very easy for me to see financial class, and I see by financial class in this pie chart what percentage of, say, Blue Cross represents my patient population. And I also see the number of encounters by carrier and the percentage of the patient population that has that particular financial class. This is important for you to understand who's coming to your hospital, who are you discharging, what services are you providing, because I can look at this also not just by financial class, but by provider, by service line, by DRG. So if I selected the Department of Orthopedics, and then I wanted to look at all the cases by certain DRGs, I could understand what percentage of my population I'm discharging that has, say, a total hip replacement, and then understand very easily the length of stay, and if there are readmission, the margins, which physicians contribute to those margins the best. It's very easy. Discharge length of stay and in-house length of stay are, of course, important, and being able to see this information in a way that allows you to intervene is even more important in improving your bottom line, because obviously operational aspects, quality aspects have financial implications. So when I look at discharge length of stay, here I have Crabtree again. So I'm beginning to be told a story about the Department of Orthopedics in terms of what cases Jean Crabtree sees, what levels of acuity Jean Crabtree sees, what types of insurance her patients see, and is she profitable or not. that's important for me to be able to do and understand why she is an outlier in a good way or in a bad way. And for physicians with the most in-house patients, I want to understand, how are they doting on their patients? Are they getting them out the door fast? Are they solving the problems in a way that makes them, not be a readmission statistically, and allow you to ask questions about different service lines, different providers. So this is basically an easy way to understand your length of stay and how you're trending. Length of stay, obviously we can't affect length of stay if we don't understand immediately who is not being discharged on time. So we take it another step further, and we want to understand in the Department of Orthopedics, okay, for all sites, please tell me which patients have not been discharged before 11 o'clock or discharged after 11 o'clock. And I can see that the red ones were all patients that were discharged after 11 o'clock. So they were discharged late. Now there could be a backup in the cath lab or in post-op, or there could be, we have bodies in the hallway, which is something that happens. You see a bed in the hallway. Somebody's waiting for a room. So we want to have a way for you to easily see, without running up flights of stairs, without calling people who are busy with a catheter in one hand and a bedpan on the other, what is your ability to take on another patient, who is getting discharged when and where and why. And you can see here on my right, my discharge summary bar unit allows me to answer and ask those questions. And I can easily find out why somebody wasn't discharged on time. Looking at patient census is important for understanding your workforce and understanding your overall ability to handle new business. So we have room charges trends for FTI East Nursing Unit 5. And what it's showing me here over a period of time is where my average is and how I differ from the norm. So it's important for us to see that on Sunday to Sunday in a given time frame, from ambulatory surgery to nursing units 1 through 16, for example, what was my average daily census? This would help me compute certain things about productivity analysis of staff, productivity analysis of the services you're providing, the throughput in the ED. Where are they coming from that's driving these volumes? You want to drill into understanding your average patient census per day of the week so that you can be more prepared the next day of the week. There may be certain phenomena that you just can't understand unless you look at them, and they may not make sense unless we see a trend over time. There's a certain level of unpredictability in your healthcare, in your space, in your industry, when you don't know who's coming, when you don't know where the accidents are, where the falls were, where the surgeries are coming from. You can't really plan on how you can serve your community. So by showing you a way in which you can see trends for average daily census, it will help you prepare just a little bit more. You may say, okay, it's a Monday or it's a Friday, we're going to be busy. Down here, I can see right here, we're going to be busy on Mondays in your nursing unit 9. It's a fact. It's going to happen. And up here, I can see that these visits here in gray, you're definitely going to be really busy in those units on basically every day of the week. Looking at procedure analysis will help us understand what you need to know about the most prevalent procedure codes. Just a way for you to see what is going on in the hospital, what are these patients, where are they going, and why are they here? So we want to give you an understanding of the types of procedures that you're doing. What you're not seeing off to the right is the legend for these colors, which didn't make it into the snapshot, the screenshot. But these different colors refer to different types of physicians who are performing those procedures. And you can obviously select a different surgery center or a different product line, such as cardiology or orthopedics or dermatology, what have you, and understand what physicians are performing what procedures. When we look at finance and operations, we understand financially how we're doing and operationally what's going on behind your walls and doors and elevators. We next want to understand what the outcomes are and what the quality of care is. So obviously it's important to CMS for you to report on quality, and you need to report on attributes such as clinical core measures, which we'll talk about, as well as certain intangible things that aren't just sitting in the hall closet, like mortality rates. In the future, it'll be Medicare beneficiary spending. You know, how cost effective were you? But right now, we're going to look at some of the core measures. Well, I shouldn't use the term core measures, but some of the key attributes of quality management, which need to be managed on a regular basis in order to deliver quality. If you look at these things just every 30 to 60 days, you won't have an ability to intervene on something that's trending the wrong way. So what I'm showing you here is readmissions. Do they tend to occur after certain days of the week after discharge? Well, what we're showing you here is a readmit count gap. These are showing you the days in which there was no readmissions over a 30-day period. So it's showing you 4 days, 5 days. In this case, you had many days where you had no patients that were discharged 20 days ago. They showed back up again. So we're looking at readmissions in a summary by financial class, but I might want to look at readmissions as a summary by provider or by service line, or maybe by the whole hospital in a particular date range, just so you can understand who is responsible for these patients being readmitted. Is it a provider? Is it a course of care? What is it exactly that's leading to it? Is there a frequent flyer? And when we understand readmissions, of course, which is a Medicare requirement for you as well, we also want to understand mortalities trending over time. And this is another one of the third section of value-based purchasing is mortalities. Obviously, CMS is interested in seeing fewer deaths in hospitals. Obviously, we don't want hospitals to be a place where people go to die. We want hospitals to be a place where they go to get better. But some people die in hospitals. It's a fact. So how do they trend over time? Just an important thing to dote on to make sure that you're meeting certain benchmarks, a national standard or exceeding it, and so that when you look at value-based purchasing, you're showing an improvement or at least an achievement score in the first year. In years 2, 3, 4, and 5, up to 2017, we're interested in trending mortalities pretty stringently because your peers are also trending these things, and the benchmarks are going to be tougher and tougher to meet. So you have got to see this stuff on a regular basis to understand that you're providing the best care you can and that you're avoiding death, basically, where you can. Resource utilization is obviously important. We're looking here at a way in which to see quantities used and gross revenues changes over time. So what I'm looking at here is the quantity used, and then right here I'm looking at the gross charges over time. So I've got a problem here because I see that there's a lot of quantity being used, and I see that the gross charges over time are flattening out. So what I'm concerned about in this particular slide is people like Dr. Bradley, who have very high supply charges on average, that they're very interested in using revenue codes that you're concerned about. They're using a lot of lab, they're using a lot of pharmacy, they're using implants, they're using supplies, they're using the OR, they're using oxygen, they're using blood bank, or whatever it may be. Try to understand which physicians are driving your variable costs, and to what extent are you actually utilizing some of your resources to the most profitable extent. And we can do customizations around this data as well. And again, the data model has already pulled together all the data that you've seen. So if you wish to take a look at this data by, let's say, surgery, and you want to look at block time and turnaround time and what that means to the profitability of certain surgeries, we can begin to tie that data into the data model and give you a nice surgical dashboard showing you the profitability of certain ORs and the profitability of certain cases, the profitability of certain days and times and staffing mixes, profitability of certain physicians that request certain block times. Diagnosis analysis, this screen is very simply telling you the most prevalent diagnosis categories and in diagnosis codes. We can do this either by the entire hospital or do it by surgical unit or by service line. So now we've looked at finance, operations, and quality, and now maybe we also want to look at something like payroll and overtime and staff management. We want to trend expenses for overtime by pay code category. In other words, are irregular overtime, paid time off, and paid time off unscheduled. We want to see when we're trending for the most overtime. In this one particular paid overtime period right here, around March 1st, I see that my paid time off and sick is the highest. Well, maybe a lot of people take vacation after a long winter in the first week of March, right? And maybe there's certain people that are repeat offenders for most sick time. Maybe some people are earning too much overtime. We want to be able to alert you to these trends so that you can make changes that affect your bottom line before it affects your bottom line, not after. So looking at year-to-date payroll expenses by pay code category is important, and looking at payroll expenses by pay code category in terms of regular, paid time off and sick. I see my regular pay is pretty high for pay period, so I have year-to-date and pay period. And what I'm looking at now is I see I have a big bubble for red, and I see $117 million. That's my year-to-date payroll expenses by pay code category. Wouldn't it be nice to go back and take a look at where that money was spent and who earned it? Are they still with you? Have they been a good employee? Did they have a review? Is that person doing a great job just on regular pay, or is somebody else doing a great job always getting overtime? Is someone else a top earner who is a nurse practitioner or LPN, and they should be doing more high acuity cases, but instead maybe they're down in a place where you should have an RN or a CN? So we want to make sure that the correct labor care role is selected so that what drives your costs for labor are also what drives your productivity, so that you have the best people in the best places. So we're not just trying to keep track of the dollars. We want to keep track of the people who earn the dollars and make sure that they're in the right place. So overtime as a percentage of total salary, I can take, because I've integrated your names and all of your HR data with all of your payment data, I can now take a look at how you trend overtime as a percentage of salary and who the top overtime earners are by labor care role, by pay period. And I will actually see the names of those people and a percentage of the salary, which is overtime. If a lot of people are getting overtime, you know, it's funny, you talk to people and they say, oh yeah, well Janie and I, we've always worked together. That's the way it's always been. Well, maybe you find out that they're both working Saturdays, and that gets them into the overtime trend, and they've both been there a long time, and it's too much money. Maybe you're realizing that you should have a different labor care role. Maybe a CN would be appropriate instead of an LPN. Maybe you should start breaking people up. Maybe if one person just works 1 or 2 days a week, that's requiring someone else to work overtime. Maybe you should find someone that works 3 or 4 days a week and have the other person just work 3 or 4 days a week and not have as much overtime. So being able to drill in and analyze your business is what we want to help you do. Unscheduled paid time off against paid time off. Again, I'm just trending my costs for salaries against overtime utilization correlating with unscheduled paid time off. So it's just what I was talking about. Is it the case that unscheduled paid time off, you're having too many people take vacation or unscheduled time off at once, and that's forcing you to pay a lot of people overtime? Well, something will need to be analyzed there and done about it, and we've got screens, other screens in our productivity area, dashboards that will help you see that. Workforce demographics, we want to be able to reward people by making sure that you understand where they come from, what role they are undertaking, what they're being paid, are they due for performance review. You want to incentivize them. You want to keep your good employees. You want to keep them happy. So you understand who's being overworked, underworked, what role do they have. And when you begin to look at this information on a regular basis instead of every 30 to 60 days, you begin to actually become familiar with the names and say, geez, this person here, they're and overtime again. I just can't have this anymore. So we've got a few things that are new as well that we want to talk about, and I've been alluding to some of them. But let's talk about productivity, and we'll come back and we'll talk about the ED in a moment. Productivity is an important aspect of your business because labor, as we all know, is about 60% of your budget and makes up probably about 30% of your variable budget. Obviously, the gift shop, cafeteria, security workers, they're going to show up, administrative people, but your care workforce is variable. And we want to make sure that it's being maximized to the extent that it can be. And what we want to help you do between your different floors and walls and the cavernous facilities that you have is to be able to see an overview of where people are and what they're doing. What I see here is different months of the year, I could look at this over all volumes or just, select certain volumes. I could look at just the month of January, just a few weeks of January, but this is showing me how I trend over time. And when you were to go live with our system on day one, because we have a data model already built, and because we have dashboards, you immediately begin to see this information with your historical data, and you say, wow, are we off target? You say, holy smokes, were we off target? You look at January, for example, you had negative variances in many different places. You were overstaffed most of the time, but you were understaffed as well. And in this month of February, you were understaffed incredibly in the second week of February, and you trended okay, but you had other areas where you were out of whack. So those were in different months. But the idea is to be able to make this line as flat as possible. And this relates to value-based purchasing because one of the things we don't want to have happen is you not get your reimbursement incentive for Medicare. One way to ensure that you will get it is to dote on these areas of productivity every single day. Because the top two things that brought down the patient experience of care score, which is 30% of your total performance score for Medicare, was squeaky wheels on carts, over-talkative nurses, and a lack of customer service. Well, squeaky wheels on carts, you get your own WD-40. But what we will help you with is over-talkative nurses that are in areas where you are overstaffed, okay? You are overstaffed in this particular area, and you need to let some of those people go to a different area where you're understaffed so that they're not sitting there gabbing when you only have 2 patients and you have 6 nurses. You've got talkative nurses. Another area where you have 25 patients and you've got 3 nurses, you've got unhappy patients looking for remote control, asking for some water, asking for some meds, wanting to go to the bathroom, needing something. And that results in a low patient of care experience. They're all directly related to your workforce, and there's nothing you can do about it. It's directly related to your ability to care for your patient. So we want to be able to make sure that you understand what your ratios are and how you're trending. And when we look at volumes, staff clocked in, target ratio, and actual ratio, we see a variance. This is another way of looking at the data in a similar way, and it's a way to see different weeks of the year. So you can see on Sundays, week 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, how you're trending. You want to make sure you understand this. So in combination with your overstaffed dashboards, your unscheduled paid time off, your overtime earners, productivity, we want to help you see where your people need to be so that you can recover capital on labor. And when you can recover capital on labor, you can start to do more things with your money. You can start to offer more services potentially. It's your business, but certainly we don't want to be wasteful. So we see positive variances, which is a sign of overstaffing. And I see negative variances here, which is a sign of understaffing. So here I'm looking at a way in which we have variances to target. If you are overstaffed and you have too many people in an area, it's going to show up in red because it means that you have too many people. You're over the target. You're spending more money on caring for those patients than you should. So just in this one particular unit here in February, and we update this every 4 hours, I could set my reminder to either 12 hours or 4 hours or 8 hours or whatever, or what have you. But if you look at it every 4 hours and say the charge nurse or somebody else who's in charge of managing your staffing can take a look at this dashboard, they can see where you're off target. And all the areas in red are areas where I have a negative variance, which means I'm overstaffed. And if it's a green, I'm understaffed. I think I might have said it backwards in the previous slide. I'm looking at a cost variance for this 4-hour period in just one unit of $42. There's a lot of units here with a cost variance of about $42. I want to be able to recover those dollars in real time and reassign staff by labor care role, by time clocked in and name to more productive areas. And going back to overtime users and staffing and your ability to see the key overtime users by labor care role, this will help you steward your course towards capital recovery and more efficient labor operations. Accountability measures is a new scorecard for us as well, and this is obviously based on the measures which you decide that you're going to track out of the 49 measures. You'll obviously choose 13. The KPIs for heart attack care and heart failure care are the core areas for value-based purchasing. So we want to help you trend these and capture this information by certain benchmark percentage so that you're always reaching the minimum benchmark so that you can have an improvement score against your peers that is reflective of a bonus, not of a reduction. So this is just heart attack and heart failure, and I can drill down to the patient level of detail. I can obviously drill down to which surgeon it was, or which unit. I can track these details. All these dashboards kind of come together under one on core measures detail. And these 9 core measures are tracked and they are trended over time so that you're easily able to see who's meeting the requirements and who's not. You know, the whole hospital could be affected by a small group of people who see a high volume of a particular type of patient. So we want to make sure that everybody is trending in the right direction in terms of being compliant on core measures. Because it's not enough to report on it. You want to improve against your peers. So reporting, I know you'll tell me that you have this information already, but can you see it every day? Can you drill down to the service line and provider level of detail? The emergency department is a profitable area for you, of course. It's where you receive, on average, about 15% of your patients, according to AHA. So a decent amount of your revenue is going to come through the ED. I think AHA quotes about 20% of your revenue actually comes through the ED. You want to understand, are there frequent flyers? Are there readmissions? What are your most busy days? What's the time that it takes to get to a physician? You know, how are admitted ED patients leaving the hospital? Have they been taken care of? Were they not admitted? Were they not seen? Did they get tired of waiting and go someplace else? There's a certain level of uncertainty when you have an ED. You're staffed for certain types of visits, but how can you best plan? The best way you can plan is to understand what's happened in the past and, as much as possible, what's currently going on. So when we look at where patients are coming from, we understand by financial class where they're coming from what zip code. So this happens to be the Buffalo area, and I'm showing various different zip codes where my patients come from. Do they drive right past another hospital that's a competitor of yours to come to you? That's important to know. Do they see various different hospitals but choose yours because your wait time is less? Do you have a better reputation providing quality and value and for best service? Do you take care of them based on the insurance that you provide? So what we try to do with this software system, especially with the ED, is to ensure that the unpredictable comes as predictable as possible. Because we know that every single day is a challenge in terms of being profitable and productive. There is a lot to do to take care of a patient. But there's also a lot to do to make sure that you get that patient. And the ED is a place where you've opened your doors to say, we'll take care of you. You come to us. We will take care of you. Well, how long does the treatment of a patient take? So I'm looking here at a histogram of understanding how long did it take for a patient to receive triage based on what level of acuity. So, my wife and I, we had a new baby, and we ended up going to the ER 2 days later, like every new parent. And they saw us within like 2 minutes. You know, you walk in there with a crying infant, everyone's all over it. So what is your response time for certain types of cases? How many minutes does it take for you to see a triage nurse? How many minutes does it take for you to see a physician? Do you have a pediatric person on call? Are you ready to compete with other hospital that does? Can you handle pediatric cases in the ER, or are you just handling other types of more acute, unpredictable cases? FTI Catalyst is offering expertise in data warehousing, a data model, and dashboards. Our ability to deliver data, to steward your course towards profitability, performance, and productivity is based on 17 years in the business of being able to be successful in working on BI projects. It is not only has been in healthcare, it's been in other areas. We are in healthcare now. We are familiar with the types of data that you are looking at every single day. We understand lengths of stay, readmissions, We understand value-based purchasing. We understand the many core systems you're looking at in terms of EMR. We understand procedural codes and demographics and some of the nuances that a non-healthcare company necessarily wouldn't understand. So we're here to help you steward your course towards data delivery, and we hope that you'll choose FTI Catalyst. Thank you.